Getting the recording is one part, but the next step is to mark it, to choose whether this is a case that's worth submitting, and then to have a good selection of cases that showcases your capabilities. The first thing to be aware of, the RCA is here to make sure that you are safe and fit for independent practice. That's what examiners are looking for. Somebody who is able to practice safely and is fit for independent practice. So when you're reviewing your cases, make sure that you have this in mind. That's what examiners are looking for. Then you'll be able to think about whether this case is showcasing your capabilities as a safe and somebody who's independent to practice as a GP. There are many reasons why candidates fail, and today we're going to address at the 3 reasons, which is not marking your cases appropriately. So not looking at the marking sheet and looking at whether you've managed to get these points and whether this is a clear pass or whether this is a pass or fail, because these are nuances that you need to be looking at. So other reasons are not submitting the right cases and not selecting your cases appropriately so that you don't showcase the best version of what you can get. So first thing is the marking. Just looking at your recording and marking it without having a good understanding of the marking sheet will not be helpful. So it's very important that you actually study the marking sheet, because each of the word written in the marking sheet has been put there for a reason. So make sure that you study it, and when you're marking your recording, do it in a way that's very objective from an examiner's perspective. So don't try to be lenient on yourself. Be very critical and mark it as somebody who would mark it conservatively. So the first thing you need to look at is a global. So whether this consultation is organized, whether it's structured or not. If a consultation is not organized or there's a lack of structure in it, it's already not a good sign, okay? So it's not a very good recording. So that's what examiners are looking at first before they go on and look at the data gathering, clinical management, and interpersonal skills. So if the organization is not right from the first point that you're recording it, then it's not a good impression, because it doesn't show that somebody who is operating systematically. And then the second thing you need to look at is the priorities or issues. Have they been recognized? So if a patient is presenting with various problems, you need to make sure that when you're marking it, whether the main priority has been recognized and the other things that's been discussed, have you actually made sure that you've addressed it, or you've made a plan to address it at a later date if necessary? So you need to make sure that the problems have been categorized and dealt with the urgency that it requires. The next point is to look at your time management. So the hallmark of a good consultation is when you're actually transitioning from data gathering to clinical management at around minute 6. If you're doing it at minute 8, then what it tells the examiner is that you're going to squeeze your clinical management for 4 minutes. So it's unlikely for you to score well in clinical management if you're actually squeezing that in only 4 minutes when you're actually taking so long in data gathering. So that's another hallmark to look at in your consultation. You might find that your consultation may last longer than 12 minutes. If it's lasting longer than 12 minutes, but you manage to get most of the key points in the clinical management within the 12 minutes, then if you don't have any choice, then you might have to submit it and see what that actually gives you. But ideally, you want it to complete by 12 minutes. Obviously, there's things that's not that important that the patient tells you, like, how will I know about the appointment? Will somebody ring me? Like, these are things that ideally you don't want beyond the 12 minutes. You want to have already addressed it so that the patient don't have to ask you this and go beyond 12 minutes. Okay? And then the fourth point is a selection of the recording. So if you're submitting cases that's not a very good choice, then you're unlikely to score well because you're already limiting your ability to score. So make sure that you're not breaching the rules that the college has put in place. So make sure that you're respecting the dignity of the patients and you're not showing excessive flash if you're doing video recording. So how do you mark your cases? In data gathering, what you want to be looking at is whether your story is focused. Have you got a history that's focused to the presenting complaint? You're addressing the problem at the heart of the consultation. Are you eliciting relevant information? Are you picking up these cues? And then in clinical management, are you making sure that you got a shared understanding with your patient and you're making a safe management plan? So what you don't want to be seeing in recordings are recordings where you're making a generic plan. There's no shared understanding. It's a doctor-centered management, and that would not yield you good score in clinical management. That's very important to make sure that your clinical management is patient-centered. And then for the interpersonal skills, what you need to be looking at is whether you have a good self-awareness about the emotion of the patient. Are you being supportive? Are you helping your patient and doing everything you can to help your patient? So it's more about the interpersonal aspect of the consultation, the human-to-human connection. So if you're doing something like robotic, going by formulaic intent, going through checklists, this is not what you want. You want to be having a conversation with your patient where the conversation is flowing and you're able to help that patient and support them in making decisions. The approach to the marking would be to make sure that you think from an examiner's perspective when you're assessing your recordings, and evaluate your recording against a marking sheet. And then once you've evaluated that, then put a yes or a no. Either you need to be doing that as you go along. Don't wait until you've got the time to submit and then you're doing it. You want to keep doing it so that you can improve your consultation as you progress. Make sure that you study the data gathering marking sheet. So if you look at each of these phrases, it's very important that we highlight the importance of a focused history that allows safe assessment to take place. So what it means is that you need to make sure that your history is to the point. You're not asking so many things that's not relevant. And you need to make sure that you're actually covering something so that you get a good understanding of the problem. And it's important that in your history, you're eliciting new information. This is why follow-up cases don't work very well, because a lot of the information have already been elicited. So you're not really eliciting new information. You're actually regurgitating back what's already been discussed and what's probably in the patient's record. So avoid follow-up cases if you can, because it's unlikely that it's going to score well. The next point is to make sure that you're ruling in and ruling out serious, significant diseases. So this is where it's very important that you show that you're considering various pathologies, you're making use of red flags, because if you're not doing this, then it's not going to be a safe assessment. So that's why it's important to keep an open mind and you don't actually narrow down your differential too quickly. So once you have teased out what it could be or what it's not, then you have a good understanding of what's going on and you can make a hypothesis about what's the diagnostic problem here. So that's a medical bit that we've covered. Now, we also need to look at the psychosocial context. So the psychosocial context will help us to understand the impact of the illness on the patient's life. It's very important that when you're eliciting this, that you do it within context. Try to avoid asking questions, how how things at home or who lives with you at home, because it's just formulaic, and you want to avoid that. Instead, what you want to be doing is to ask the patient, how is this headache affecting what you can do at home? So you put it in context. That will be more useful, because then we're getting a picture of what's the impact of this headache on the patient's life. Examination is something that depends on the case. In some cases, you may need to explain examination and perform examination. Don't take a long time on examination. Make sure that in the examination, if you're actually asking for an intimate exam, that you mentioned chaperone, because that's very important for interpersonal skill. And make sure that your explanation for the examination is simple, or if you're discussing about investigation, keep it simple. If you're using a lot of jargons, I would not actually recommend that you use recordings where you're using a lot of jargons, because it's going to affect your mark. The last part in the data gathering is showing that you recognize issues or priorities in the consultation. So this is where if there's multiple issues, are you managing to address these issues? So in one recording with a time of 12 minutes that you've got, it's unlikely to be able to manage more than one issue correctly. If you're getting a patient presenting with 2 problems, it's very important to actually recognize which one is most pressing, and then signpost the patient that we might not have enough time to deal with everything today, but I'll try my best, and then deal with the most pressing problem, and then let the patient know that this problem, we might need to give it more time on another day to deal with it. So by doing that, you're showing that you recognize issues and you're making priority according to the urgency. Okay? Does that make sense so far? Right. So now with the clinical management, once you've got your medical history, you've got your ideas, concern, expectation, your psychosocial, the next bit would be the working diagnosis. So it's important that you verbalize the working diagnosis to your patient. So when you're going to mark your cases, ask yourself whether did you verbalize it. If you haven't verbalized it, it's very difficult for examiners to understand what are you diagnosing, what are you managing. And for the patient, it's not great neither, because they don't know what you think is going on. So that's very important. As long as you're actually verbalizing it, then it's likely that your consultation will be more clear and you will have a better plan in place. The next point is to offer appropriate safe management options, and this is in relation to the presenting complaint. So if a patient is presenting with a problem, make sure that you're doing everything you can to help them with that problem. So make a safe assessment, manage the problem, and there are various ways of managing the problem. There are things that the patient can do themselves, lifestyle modification, and then there are treatment that we can discuss with the patient. So make sure that when you're discussing treatment, make sure that you highlight the fact that you need to be evidence-based in your decision. For example, if you're prescribing amoxicillin for chest infection, it's important to verbalize, I'm going to prescribe you an antibiotic called amoxicillin, and this is in within the local guidance. So let the patient know that you're prescribing safely, and that is what's recommended in your local pathway. So at least then the examiner get an understanding that the reasoning behind your prescription. So it's also important that you discuss the side effects, the pros and cons of the treatment. If you just prescribe something or discuss and share option, that's not enough. You need to be discussing the pros and cons of this treatment option, because otherwise your patient is not able to make an informed decision. So make sure that you're discussing it. For example, if you're referring a patient for a colonoscopy, it's important that the patient understand the reason we're doing it, Why are we doing this? Are we afraid that there's some problem like cancer? We need to investigate something. What can they expect from this referral? Do they need to expect that there will be an appointment within 2 weeks? So that's things that you need to verbalize in the clinical management to score well. And also, do they need to have bowel preparation? This is something you need to discuss with your patient. So not just referring or telling them that I'm going to do this. Make sure that you explain what's going to happen and the pros and cons of doing the referral. And then sometimes you might need to coordinate with other healthcare professionals. So make sure that you explain the patient what's the plan in place and who's going to get in touch with them. And if there's no need for a referral for a specific service, you think that you could signpost a patient for social prescriber or some other third sector, then give them the details and make sure that they are able to contact that service. So the other thing that I'd say is that make sure that you're using time and resources appropriately. So what you don't want to be doing is to use resources in a way that somebody else would criticize. That's not good use of resources. For example, if a patient, they're requesting a CT head scan for a headache that you don't think that's necessary, it's very important that you discuss the reason why it's not indicated and offer an alternative to your patient and attend to the risk and let them know about the risk of radiation. So that's what you're expected to do in clinical management, to discuss about what's the plan and why you don't think this is needed, but what you think that's needed, and differentiate between patients' wants and patients' needs. And then the last bit is to make sure that you provide realistic safety net advice that's appropriate to the presenting complaint. It's not good to offer just blanket safety net advice that's not realistic or not appropriate. For example, just saying to a patient, if your symptoms get worse, then call 111 or get in touch is very vague. So you want something that's more specific. For example, if you're having a fever, if you're vomiting, if you're having double vision, then I'd like you to call the surgery back because we'll need to reassess you. That's more specific. So let them know how they can reconsult, what are the symptoms to look out for, and then if needed, offer a follow-up arrangement. And for the follow-up, make sure that you're specific. For example, if you're going to see a patient in 2 weeks' time, don't say 2 to 3 weeks, just say 2 weeks, make it clear. And make sure that you're specific as in how you're going to arrange the follow-up. Is the patient going to call or are you going to book the patient? So that's very important that your plan is specific and there's no miscommunication. If you found this video useful so far, you might be interested in, are you ready to take the RCA test? This is a test that you can take where we're going to look at your answers and check whether you're ready to take the RCA based on your mindset, the strategy that you're using, and the consultation skills. The test only takes 60 seconds and you get more insights into your preparation and how ready are you to sit the RCA. All you have to do is click the link down in the description below and you can take the test free of charge. Now with the interpersonal skills, it's important in the beginning that you invite the patient to get their story out. And that's something the examiner is going to look at, whether you're encouraging the patient to actually tell their story and whether you're listening and picking up on these cues and responding. For example, if a patient is telling you that they lost their dad from a heart attack at the age of 50, if you just say all right and you go and ask another question, it's not a very good response to the cue. So you need to show your empathy, you need to show concern and ask a little bit more about what's happened, because this could be related to this presenting complaint. They told you something, maybe they're worried about their heart. So that's why it's important to respond to these cues. Then what you want to do is to explore the patient's health agenda every patient who comes in, they actually took time out of their day to consult you. So they probably thought about what's going on and they're probably worried. Otherwise, they wouldn't have come. So it's important that you get in their mind and understand where they're coming from. That's why we ask about the ideas, concern, expectation. Just asking about the ideas, concern, expectation and not doing anything about it is not enough. It's important that you make sure that you integrate your ideas, concern, and expectation in your clinical management. So when you're discussing your management with your patient, make sure that you include your patient with you. So don't just say, I will prescribe this for that. Let the patient in the decision. So tell them, as you were hoping we could do something for this headache, there's a medication called sumatriptan that we could use to help you. What are your thoughts about starting this medication? So you're actually inviting your patient to tell you what they think about this. So you need to make sure that you include your patient in the decision rather than just saying that I will prescribe this, I will refer. So make sure that you're using these phrases where you're including your patient. And making decision and sharing it is very important. So that's why it's important to make sure that both you and the patient are on the same page. So both of you understand what's the problem here. So if you don't verbalize your working diagnosis, your patient is not going to understand what's going on and they might be confused and still worry about something else. So if you don't have this shared understanding, then it's difficult to get a shared management. That's why it's important to make sure you've got a good understanding with your patient and address their ideas, concern, expectation. We've talked about the need for being sensitive and offering chaperone, and then make sure that you're using language that's simple. You don't confuse your patient with technical jargons. When you're marking your case, remember the marks that you can get. So clear fail is 0, fail is 1, pass is 2, and then clear pass is 3. For you to be able to score clear pass, the specific things that you need to do, the tasks that you need to complete, is that you need to demonstrate a high level of competence and you're justifying your approach. This is why it's important that you justify what you're doing. Why are you doing this referral? Why are you asking a question that they might not expect? So that's why you need to signpost. You also need to be fluent and appropriately focus in your approach. If you're not focused, you're going all over the place, then it's unlikely that you're going to get a clear pass. It's very important that you're showing evidence that you're able to consult appropriately and using good logic in it. So making sure that you're using the recent guidance and recommendation. And you also need to show sensitivity. You're sharing your ideas and you're empowering your patient. Now for a pass, what you need to show is that you have an adequate level of competence and your clinical approach is something that might not be as fluent as for a clear pass. There might be occasions when there are breaks in the consultation, but overall you're still justifying your approach. Your approach is technically proficient. The major problem with some candidates is that if they are submitting cases that's not complex enough, then they're unlikely to score clear pass because the case is not showing evidence enough for a clear pass. You might get a pass but not a clear pass. So that's why it's very important that you're calibrating your case and know where you stand in the case, whether it's complex enough, whether the clinical challenge is to the level that's expected. And then you need to show sensitivity and you're involving your patient. And that's why it's important to be patient-centered when you're consulting. So this is very important to think about whether your recording will yield you a clear pass or a pass. So the clear pass is where you're operating at a high level and you're very fluent and you're justifying your approach, you're empowering your patient. Whereas for a pause, you might not be as fluent, but you're still proficient. And the other problem is it could be that your cases are not complex enough. Look at the feedback statements. Make sure that if you have previously sat the RCA, look at the threads about things that you didn't do well, and then try to look at cases that showcase these important aspects of the consultation that you can manage to showcase. Because if you have a thread of problem where maybe you're not doing a shared management, then try to avoid submitting any cases where there's over doctor-centered care. So understand that you may not have regular feedback from your ES. If you're in that position, it's very important to try and see whether there's somebody else in your training who can help you. For example, another partner or the training program director. Just ask and see whether you can get help. If you don't ask for help, then you're unlikely to get help. It's very important to try and get somebody's fresh pair of eyes on a consultation, and that would need to be somebody who is in your training program, so that they can give you some feedback, and then you can grade your consultation according to their feedback. So now let's talk about the low challenge cases. Any medication requests, any pill check, follow-up, recurrence, or any results, discussion, sick note requests, these are unlikely to score you well. So if you're submitting any of these cases, you're unlikely to score a clear pass because it's not complex enough. There are 4 domains that we need to look at to be able to evaluate the complexity of a case and the level of challenge. It's the diagnosis, the management, patient, and situation. When you're calibrating your case, what you want to be asking yourself is whether the diagnosis, is it challenging? Is there a level of challenge to the management? Whether there's a layer of complexity about the patient, have they got unrealistic expectation? What about the situation? Is there social problems? I'd like to invite you on a quiz to help you go through the process of thinking about these 4 domains. So if you look at the diagnosis here, from A to E, which one would you say would be the most challenging? If you grade from most challenging to the least challenging, which one would you put first? Which one would you put second, third, fourth? I'd like you to write it in the chat. Think about, for you, which one would be most challenging and which one least, and just write it down in order from most challenging to least challenging. As you can see, so the level of challenge of a case would really depend on the person, because what might be challenging for one doctor could be less challenging for another doctor. So there is a level of challenge that would depend on your personal experience and what have you consulted before. But generally, what the college has said is that cases such as ENT, dermatology tend to be scoring lower because they're deemed to be low challenge. But the challenge is not only related to the diagnosis. So there are other things that we need to look at. So the management as well. So if you think about management here, if your management is to refer to A&E, so a patient presenting with chest pain and you refer the patient to A&E, and then you've got another patient who's actually booked to see you and has already got an ECG, and you're reviewing the patient, and your management for that patient is you're starting that patient on aspirin, on GTN spray, and you're going to refer this patient to A&E. Which one do you think is more challenging here? With regards to the management, what you're looking at is how much work are you doing in the management. So we'll come to the referral to A&E in a bit about how challenging it is. Yes, it's more uncertain, but if you are referring a patient to A&E, what you're doing is that you're probably going to do less work because you're delegating the management to the A&E department to do it. All right? Whereas for the B scenario, you've got the ECG, you can see the signs, and then you're reviewing, you're starting the patient on medication. Actually, you'll have to be doing more work in this scenario, because you're initiating the treatment, and maybe you're going to discuss with the hospital and refer to rapid access chest pain clinic or same day admission. So there's more work involved in that one. So for the examiner, when they're looking at these cases, they will see that in A, the patient's been referred to A&E, and then there's not much work that's been done in the management. Whereas in B, that doctor had to do more work. There is another aspect that we're going to look at. So there is a point here about delay of care. Yeah. So if this is going to delay the care, then you don't want to be doing that just because of the RCA. If the patient needs to go to A&E, then your advice would have to be what you'll go with, regardless of whether you're recording or not. All right. But now what happens if the patient declines to be referred to A&E? Then it becomes more complex, isn't it?
Yeah.
So then if you had a patient who you referred to A&E, they don't want to go, they ask you, can they come down to the surgery? Then you'd have to offer an alternative, because you can't just leave them like that. Yeah. So then that would add another layer of complexity here. Now, if you had a patient who would agree to go to A&E, then it's straightforward. There's no complexity here. Yeah. So for the patient who's declining admission, then you need to work harder, because you need to discuss about the consequences, life-threatening, if they don't get assessed and there's delay of treatment, then you're having to do more work to persuade them to go. Now, if they still don't want to go, then you may need to offer an alternative treatment here, okay? In some cases, you may need to accommodate for them to come down and review them and start them on treatment, yeah? So you can see how a case can become more complex depending on the management, depending on the patient, depending on the choice. Another aspect to look at is a situation. Situation is where you have the psychosocial aspect. So if you're diagnosing a patient of TIA and the patient happens to be a taxi driver, this is going to have a severe impact on the financial life, on the patient's work, and the situation is adding a layer of complexity here because he's a taxi driver. Okay, so it might be harder, so you need to consider that. Now, if you're looking at a case where you're referring a patient who has got rectal bleeding as a 2-week wait, and the patient tells you that they've got an impending move to work abroad, and they're unlikely to be able to stay here for the next 2 weeks. So that adds another layer of complexity. So there are different layers of complexity here. So the C scenario is where it's even more complex, because now you've got safeguarding issue, because you've got a single mother with heroin addiction. Now you might need to have discussion with the social services. So this case would be even more complex. So I hope you can understand the complexity here in terms of the situation. So that would be like a different angle to the consultation if you have these factors in your consultation. So when you're calibrating your cases, think about the complexities and think about the clinical challenge. So the clinical challenge is the diagnosis and the management. How hard are you having to work in the management? And then the complicating factors will be the patient expectation, the belief, psychological issues, social situation, whether they have any hidden agenda. So what you want to be aiming for is a case that is moderate challenge, has some factors that's present, complicating factors, because this would showcase a case with good opportunity to display your capabilities. What you don't want to be submitting is a low clinical challenge that does not have any complicating factors, because it's a low level of challenge and it's very limited in the opportunity to display capabilities. So because you're going to have insufficient evidence, it's not going to be a case that's in your favor. All right. On the other hand, you don't want to submit a case that is high level of challenge, that has multiple complicating factors, because it's likely to be extremely challenging and it's unlikely that you're going to complete it within 12 minutes. So you need to balance the case so that it's falling on the green zone. Now let's look at the case selection. Make sure that with your case involving a child, you actually got a case that's showing the impact of the child being a patient. Because what you don't want is a case where you have a child who's 16 years old, but you could actually be consulting an adult with the same problem and you wouldn't be able to say this was a child. So what you want to be showing is that you can consult a child and you're able to do pediatric history, make an assessment. So good cases would include bronchiolitis, reflux in baby, abdominal pain in a child. So these would be good cases. Other cases you could consider would be a 15-year-old requesting contraception, because there is a difference here, because you'll need to look at gilly competence. For your older adults over 65, it's different to the one in the child in terms of it's not really about the impact of the patient being an older adult here. Any problems with an adult over 65 would actually be a good case to submit if you're actually managing to fulfill that criteria of over 65 years old. So it doesn't need to be a care of elderly case. It could be something like a hernia, it could be something like gout, as long as a patient is over 65 years old. And then we've got the essential clinical areas. You need to have an acute problem that needs to be investigated urgently or warrant an urgent referral. So we've discussed about the complicating factors, about the level of challenge. Be careful if you're submitting a same-day admission. If you're not doing much work in the management, it might not be a suitable case to help you score well. So if you're actually doing a lot of work in the management, then it might be a good one. Or if there is a complicating factor such as the situation or the patient, then it might be a good one. So think about whether your case has got an angle to it and whether it's meaty enough. For maternal and reproductive health, I would avoid submitting any breast lump because it's unlikely to score well, and the college has updated the criteria. So if it's a breast lump, they're unlikely to actually come under this. For mental health condition, there's plenty of that. I'm sure you get a lot of these cases. Make sure that you're making a safe risk assessment. Ask about suicidal ideas, thoughts of self-harm. Ask about any thoughts of harming others. These are things that make sure that your assessment is safe. And then for long-term condition, it needs to be an established condition rather than a newly diagnosed one. So make sure that that condition has already been diagnosed and is established. So this would be like a disability, chronic back pain, cancer, or some problems such as gout or osteoarthritis that's already been diagnosed. If you've made it this far, then I've got another video that I'm sure you're going to find useful. This is a video where a registrar who passed the RCA first attempt shows how she managed to get more cases. Click the video to watch it. Take care everybody. Bye bye.